So maxillary anesthesia, we're going to start with the anatomical background. Um, if you still remember, we have the trigeminal nerve, which is cranial nerve number 5. That will give you trigeminal ganglion, and trigeminal ganglion will give you 3 nerve, trigeminal 3. Here is ophthalmic, here is maxillary, here is mandibular. We're going to start with the maxillary. And as I mentioned before, it's SRO. This is a mnemonic for the foramina through which the 3 nerves are going to exit. So the 3 nerves leave the skull through these 3 foramina, through SRO. Superior orbital fissure, foramen rotundum, foramen ovale. So obviously we're talking about the maxillary now. It is foramen rotundum right here. Once it exits out, the maxillary nerve is going to give you to participate in making this sphenopalatine ganglion. And the sphenopalatine ganglion will give you the first 3 nerves that you have to know and you're going to work on. Specifically 2 of them. The first one is this, which is called the nasopalatine nerve that will exit through this foramen. If you still remember the skull, it will exit through the incisive foramen in the front of the palate. Second one is greater palatine, will exit from greater palatine foramen. And the third one is lesser palatine that will exit from the lesser palatine foramen. So you get 3 coming from the ganglion. Maxillary nerve will then continue, and it will give you the first of 3 major nerves. All 3 have the same name, superior alveolar nerve, but it will go like posterior superior alveolar, middle superior alveolar, anterior superior alveolar, posterior, middle, and anterior. But it goes like this. You give the PSA first, the posterior superior alveolar, and then the rest will continue as infraorbital nerve. The infraorbital nerve will give you the MSA or the middle superior alveolar. They usually use these abbreviations, so familiarize yourself with these. Uh, and then we'll give you the ASA, which is anterior superior alveolar, and then it will exit through infraorbital foramen, and it's the infraorbital nerve. The infraorbital nerve will give you branches to the lower eyelid, palpebral branches, nose, nasal branches, your upper lips, superior labial branches. So remember, we're doing the anesthesia. If you block this, know that you're not intentionally trying to get your lower eyelid and or the patient's lower eyelid and nose and upper lip. You're not trying to do that, but if you block the infraorbital nerve, these are going to be blocked. So you got these 4 nerves. You got three first, and then these 4. This will make it 7 nerves altogether. If you notice here, look, each one of these nerves, like look at this, the posterior superior alveolar will give alveolar branches that will enter the root of the teeth through the apical foramen together with the artery and vein. So this is how it's going to work. They're going to give you alveolar branches from the posterior, then the middle, then the anterior. All those 3 are going to go to the teeth. This is join to the infraorbital nerve and then exit. No. And let me just go back. Here is what I said. I said the PSA will come from the maxillary first, and then the rest of the maxillary is called infraorbital. The rest, after you give, so you give the ganglia first, the ganglion, and then you give the PSA. still maxillary nerve. And then the rest will continue as infraorbital, giving you MSA, ASA, and the rest is going to exit from the infraorbital foramen as a continuation of the infraorbital nerve. So maxillary nerve give you the ganglion, which will give you three nerves, and then give the PSA, and then the rest, it will continue as infraorbital nerve. Is that clear, Maisa? Yes.
So you said that the MSA and the ASA are the only ones that like join to be the infraorbital nerve. It's not the PSA is separate.
The PSA come from the maxillary nerve. MSA, ASA, they come from the infraorbital nerve, which is a continuation of the maxillary nerve.
I see. Okay, thank you.
You're welcome. If you still have a question, let me know. You're fine?
I'm good, thank you.
Okay. All right. So um, here is one more thing that I want you to notice. Again, here is a trigeminal nerve. This is a trigeminal ganglion right here. And then you have ophthalmic, maxillary, and mandibular. Maxillary will exit through this foramen right here, which is foramen rotundum, and will pass for some time here. Look at this. This is important. And it will give you this ganglion, which is a sphenopalatine ganglion. Sphenopalatine ganglion will give you nasopalatine, greater palatine, lesser palatine. Remember, sphenopalatine give you three nerves. All of them are called something palatine. And then it will give you the PSA, which is this one right here. The rest is the infraorbital that give you MSA, ASA, and then it will exit through the infraorbital foramen. What's different in this picture here? The difference, or what I want you to notice in this picture here is, I want you to look at this region here specifically. If you look here, if you guys still remember this, I did this like so many times. Remember this pterygomaxillary fissure, and then you have the sphenopalatine fossa. If you guys still remember the fissure and the fossa, so if you target this area, you're going to this point specifically. And this is the main maxillary nerve before it gives any branches. So if you put your anesthesia here, if you drop the anesthesia in this fissure, it's going to block the whole entire maxillary nerve before it gives off any branches, because before it gives the ganglion, before it gives the PSA, MSA, ASA, infraorbital, before giving anything. This is called the maxillary nerve block, or V2 block, or maxillary nerve block, okay, or the whole maxillary nerve anesthesia. So that's why I brought this picture to show you this part specifically. Um, Still doing the anatomical background, there is something called incisive papilla. You can see it if you put like a mirror or something, and you can see it here. It starts in between the two central incisors, and you see it right here. What's the importance of that? It's a very important landmark for the incisive foramen that should be here. So at certain point, you're going to target the incisive foramen to anesthetize the nasopalatine nerve, and you will see that. Okay, so this is the incisive papilla. It's a projection on the palate near the two central incisors. I want you also to know these veins because when we do the actual anesthesia, you will notice this, that when you inject anesthesia, before you start injecting anything, you should draw. It's not called draw, it's called aspiration. Aspiration. So you should, like when it's different when you inject or when you take a blood sample, for example, as if you're taking a blood sample. It's not You're not taking a blood sample. It's just called aspiration. So you're pulling out. So if you pull out the plunger, when you pull it out, if there is blood, it means you are wrong. You are in the wrong location. You did something wrong. So that's why you have to do 2 negative aspirations every single time you do any anesthesia. It should be something automated. It should be something that goes without saying. You have to do 2 negative aspirations. So in this case, if you're doing like the maxillary nerve block and you get in here, and if you reached the pterygoid plexus, for example, you will see blood coming out with your aspiration. This is called positive aspiration. So you're doing something wrong. You cannot inject. Pull it out. Pull your needle out and know that you went too far. So that's why you have to make, otherwise you will be injecting your anesthesia in one of the arteries or veins, which is a big problem. So that's why you have to do it. So remember these structures right here: facial vein, the pterygoid plexus of veins, the cavernous sinus, that if you inject something, it can go to the cavernous sinus, which is a big issue because it's beside the brain and other structures in there. Also, there is an ophthalmic vein here. So this is important because it's in your structure list, and this is something that you can get into while you're doing the anesthesia. Now, I mentioned the nasopalatine nerve, greater palatine, and lesser palatine, the 3 branches that come from the sphenopalatine ganglion. Remember, the ganglion is like this, coming from the maxillary nerve itself, and then you have one nerve goes to the front like this: nasopalatine, greater palatine, and lesser palatine. You have 3 nerves. So here it is. This is the first one. This nerve right here is a nasopalatine, and it exits from the incisive foramen. This foramen right here, remember the incisive papilla that's located here. So it's covered, partially covered by the incisive papilla. That's why we needed to know that. And it exits out of the incisive foramen or incisive fossa, and this will be your target if you wanted to block the nasopalatine nerve. And I want you to notice these black lines right here. I put this here for a reason. This is the territory of the nasopalatine nerve. It's going to feed this area right here, everything in here. This include the palate? Yes. Does it include the medial aspect, or we call it the lingual aspect of your soft tissue of the gingiva by the teeth? Yes. How about the greater palatine or greater palatine nerve? The greater palatine nerve is going to feed this area here, or actually up to here. So it's doing the same thing, but instead of this front, it's feeding the rest. So in order to make it easy, I say, excuse me, I say canine to canine. Remember, this is central incisor, lateral incisor, canine. So it's canine to canine. Canine, the inside of canine to canine. This is the territory of the nasopalatine nerve. Anything else? The other 5 teeth, the 2 premolars and the 3 molars, anything medial to those is the territory of the greater palatine nerve. Lesser palatine is not the most important. It feeds some soft tissue that's not important for our anesthesia. So we're focusing on those 2, nasopalatine or nasopalatine and the greater palatine, and we talked about the distribution. You can see it again here. This nerve right here is the nasopalatine. This is the greater palatine, and this is the lesser palatine. And arteries are in your structure list as well, because when you do the aspiration, if you do an aspiration and you get blood, you might be getting into one of these arteries. That's why we have to know it. So the nasopalatine nerve is accompanied by sphenopalatine artery. Otherwise, the other 2 arteries have the same name of the nerve. So in the nerve side, you have nasopalatine, greater palatine, and lesser palatine. In the artery side, you have sphenopalatine. This is different. Sphenopalatine accompany the nasopalatine. And the other two are the same, greater and lesser palatine. This picture is extremely, extremely important. You have to know this picture, okay? You have to memorize it. It needs to stick in your brain and don't ever forget it for the purpose of the exam, for the purpose of anything, for your practice, for anything. This should stay all the time in your memory. Let me remind you, canine to canine. The medial aspect of canine to canine, which are the inside of those 6 teeth, central incisor, lateral incisor, canine. The palate side, the green here, the palate side, and the lingual aspect of the soft tissue of the teeth will be numbed if you numb the nasopalatine nerve. This is the territory. Here is the greater palatine, which is the palate, and the medial or the lingual aspect of the gingiva or of the soft tissue of the other 5. So it's only 2 feeding this area. For the teeth itself and the outside, which we call it the buccal side, is different. We have ASA, MSA, and PSA. The orange, which is ASA, will be feeding the same territory of nasopalatine, but from the teeth and the outside aspect. Okay, so if you do ASA, this is your territory right here, the orange, including the teeth, including the outside soft tissue. If you go to the MSA, it's going to feed the 2 premolars and the outside. All nerves are feeding the outside anyway. These 3, ASA, MSA, PSA, all of them are feeding teeth and outside, which is the buccal aspect of the gums. MSA is feeding the first premolars, and the last one, which is the PSA, is feeding the 3 molars. But in some people, many people have one of the roots. You know that the teeth will have roots, and these roots have names like this. These are the roots. These roots have different names. This root right here, which is called the mesiobuccal root of the first maxillary molar, this is also innervated by the middle superior, the MSA. So when you say the MSA, you say the 2 premolars plus mesiobuccal root of the first molar. The rest of the first molar, second molar, and third molar, this is the territory of the posterior superior alveolar. What's the point here? The point is, if you're talking about the first molar, should I get it from the PSA? Probably part of it is not anesthetized. Can I get it from the MSA? You're only getting the mesiobuccal root. Should I do both of them? Maybe, but practically speaking, there is an alternative that you can only target this tooth specifically. In another way, we will talk about it, which is called the infiltrative anesthesia. We will talk about it. But again, this territory is extremely important. You have to know it for all aspects, from all aspects. You need to know it for everything. There is an extra thing here, which is the infraorbital nerve. And the infraorbital nerve simply will give you both of those combined. It will give you ASA and MSA combined. Actually, infraorbital is an alternative technique. We will talk about the techniques. It's an alternative for the ASA, but when you do it, you get the territory of the MSA as well. And here is the idea. If this is the infraorbital foramen, and this is the infraorbital nerve coming out of it. Remember, it's going to feed the nose, the lower lips, the lower palpebra. Anyways, inside the infraorbital nerve is running inside the infraorbital canal, and it will give you ASA and MSA. I talked about the background, and I'm assuming that you guys already get it. So if I'm going to inject here at the infraorbital foramen, the anesthesia will ultimately go inside, and it's going to infiltrate and get the infraorbital nerve itself. The infraorbital nerve will be blocked, so you get ASA and MSA. Let me know if you guys have any questions. Uh, for practical purposes, it's used as an alternative to ASA. There is another alternative out there, but I'm just giving you the basics. So infraorbital nerve, what does it feed? It feeds ASA and MSA combined. Because if you infiltrate, it will reach to the infraorbital, which you give the ASA and MSA, so you will get it. Okay. The other thing is the pterygopalatine, the pterygomaxillary fissure and the pterygopalatine fossa. Yes, Maisa, go ahead.
Sorry, I have a question about like the difference. Like, is like the palatine nerve, is that like a continuation of like MSA and PSA, or no, it's a completely separate nerve? Like it's
Which
just
nerve?
for
I'm sorry, which nerve again?
the palatine,
Palatine, which nerve?
the
Nasopalatine,
greater,
greater palatine, which one?
the greater palatine nerve.
Greater palatine nerve is coming from the sphenopalatine ganglion, which is coming from the maxillary nerve itself.
So they're separate.
Yes, let me show you the picture just in case. And if you have another question, let me know. Here it is.
I had a question about the lesser palatine nerve. You see how
Yes.
on the colorful, like the color coded picture that you were just talking about? If you want to go back.
Yeah. Let me just show you here that this is a greater palatine nerve or greater palatine nerve right here. And this is the lesser palatine, and this is the nasopalatine. All of those come from this ganglion, which is the sphenopalatine ganglion that's coming from the maxillary nerve. The rest will come from PSA from the maxillary, and the other two from the infraorbital. Yes.
Okay, so
And this one,
palatine. Oh yeah.
the less,
So there's
the lesser,
lesser
the lesser
palatine.
palatine would. I'm sorry. Go ahead.
Oh, there's no lesser palatine block over here in this image.
No, we don't even need it because it's
Right.
not related to the teeth. It's related to the soft tissues like the uvula and the soft palate. So this is not our target. It's not even related to any of the teeth. So it's not one of our targets. Okay.
Okay, makes sense.
All right. Okay. For this pterygomaxillary fissure, you saw this several times. You're welcome, Maisa. You saw this several times before, and the reason is, remember when I showed you the maxillary nerve going like this, and I told you if you wanted to block the maxillary nerve itself, you will go like this. You're going toward the pterygomaxillary fissure, and when you go to the pterygomaxillary fissure, the nerve will be going like this, crossing. Before it give anything, before it give the ganglia like here, and before it give you like the PSA and continue infraorbital to give you MSA, ASA, and then exit before everything. If you get it in this area right here, which is the pterygomaxillary fissure, and you inject there, the anesthesia will go into the pterygopalatine fossa, and it's going to infiltrate the whole entire maxillary nerve. If that's the case, you are blocking everything. If I ask you about the territory, you simply say everything, everything. Remember the color coded picture that I showed you? Put all of those together. We don't have to mention it. Everything, literally everything, the whole teeth, the whole 16, uh, um, uh, I mean eight, the whole eight teeth on that side, the outside, the inside, it's everything. Just put all these branches together: ASA, PSA, MSA, greater, nasopalatine, everything. You get it there. And the question that I always get is, why don't we just do that, if that's the case? No, the maxillary nerve block or V2 block is left as the last resort, because if you do that, it's complicated, it's not easy to do, and you can injure something. You can inject into the veins, you're going into the infratemporal region. There are a lot of delicate structures, so it's left as a last resort, and I will talk about it. But for now, I want you to know these structures: pterygomaxillary fissure, pterygopalatine fossa, the maxillary tuberosity right here, and so on. Infraorbital foramen is right here, and I was talking about this. If I go like this arrow right here to the infraorbital foramen, I will be blocking the infraorbital nerve, and you see here is going to the nose, to the upper, to the palpebra right here, to the nose, to the upper lips. What the ASA and MSA has to do with this? I just mentioned it. The anesthesia is a solution. It's a liquid. It will get inside and go inside the canal, the infraorbital canal. So you will get the infraorbital nerve, well, where the ASA and MSA coming out, they will be blocked. Um, it's used as an alternative to ASA, and you will see the actual techniques. Now there are some more anatomical landmarks that you have to know. So when we talk about it, I will assume that you already know. When I tell you, like, you're going to insert into the mucobuccal fold by the second premolar, for example, I'm assuming that you already know. So here is what we need to know. The mucosa of your cheeks from inside is called buccal mucosa. The mucosa of your gum is called alveolar mucosa. The mucosa of your lips is called labial mucosa. You got three types of mucosa right there. And you have a fold up here and a space. The actual fold, the mucous membrane, this is called mucobuccal fold. The space, like I'm putting dots here, this space is called vestibule, the maxillary vestibule. Same thing here. The space in here, like this space in between the alveolar mucosa and the labial mucosa, the space itself is called the vestibule. But the actual mucous membrane that you're going to insert into it, it's called mucobuccal fold. I hope that's clear. If not, let me know. Let me show it like this. If I insert the needle, I will pass through the vestibule, vestibule, until I get into this. This is a mucobuccal fold. So I'm entering into the mucobuccal fold. Okay, so the vestibule is the space that will take you to the mucobuccal fold. Make sure you get this. You need to notice also the relationship with the maxillary sinus, just in case, because if you're going in, there is a chance that you get into this or something. But the relationship between the PSA, MSA, and ASA, there is a relationship with this maxillary sinus. I want you to notice something here also. Look at these green branches entering. These are called the alveolar branches. Each one of those will enter through one of the roots. The roots, let's say, if this is the tooth like this, the tooth will have roots. Let's say it's like this. There is a foramen right here, and here, and here. These are called the apical foramen. you will get in, the alveolar nerve will get in together with the artery within the root. So this is called the root. And then it will get to the bulb right here. Okay, so I hope this part is clear. Now this picture, why did I add this picture here? Because practically speaking, when you start your clinical part and from now on throughout your entire life, most likely you're not going to be actually using the anatomical academic names. Central incisor, you have to know it anyway. But practically speaking, you will hear your clinical instructors or professors not referring to the tooth as the full name. Will give it a number. They will tell you today we're working on number 30. That's it, number 30. It's easier to say that for them than saying the upper right first premolar. Why should I say all of that? You know, so it's like if I'm referring to this one right here, what should you call it? This is the upper right premolar. Why don't you just say 5? So here you start from here, from the right side, and you call the first one number 1, and you go all the way to the last one of the maxillary that's called 16. And then you start counting from here, from 17 until you get to 32. Practically speaking, this is what you're going to do. They will tell you we're working on 21. That's it. Automatically, you should know what's 21. Now the techniques. We will have ASA, MSA, PSA, and then infraorbital as an alternative to SA. But there is number 1 here, which is very important and very commonly used one, which is called the supraperiosteal technique or local infiltration. If you visit a dentist or something, everybody's after you graduate, you will be doing your own thing. Like I prefer this, I prefer that, and you will see them like if I'm working on the first um, the first molar, you know that there is a good chance that the mucobuccal root is innervated by the MSA. So if you say to yourself, if I'm working on this, maybe I need PSA and I need MSA just in case. No, they actually do something called local infiltration or supraperiosteal technique. All what they do is they say, okay, let's see, this is the tooth, and these are the roots, right? And the nerves are entering in here, and other nerves that are feeding around it is going like this. Why don't I just go above from outside and from inside, outside and inside? That's it. I just go outside of the tooth and inside of the tooth. I will go up, and this is going to infiltrate any nerve going to this area. So this is called local infiltration, and as far as I know, this is the most commonly used one. Let's just do local infiltration. I'm working on one of the teeth only. But if you're working on more than one, you should do one of these alternatives. Not alternatives, these are the basics. ASA, MSA, PSA, these are the basics. But practically, they use this number 1 a lot. Supraperiosteal or local infiltration. Infraorbital, we will talk about it. But again, if you do it, you get ASA and MSA at the same time. There is something called AMSA, that's a combination of ASA and MSA, but a different approach, and you get both of them at the same time. So is that the same as infraorbital? Didn't you just say that infraorbital will give you ASA and MSA? No, from the territory point of view, like which territory, it's ASA and MSA. Yes, both of them, but they have different approaches. And an AMSA will have extras. We will talk about it. A lot of dentists don't know much about AMSA, but it's promising now, and they are talking about it as a good alternative. We will talk about all of those. Additional techniques, nasopalatine and greater palatine. These are additional to get the inside of the teeth. And the last one is maxillary division block. our V2 division block. Remember V1, V2, V3, referring to ophthalmic maxillary mandibular. You call it V2 block or maxillary division block if you wanted to get everything. So let's go. First of all, if you're injecting, you wanted to get somewhere in between the brain and the teeth. So you're going to inject somewhere in the pathway, but we're targeting certain areas that we will talk about. But I just want you to see this here. Look at this nerve here going into the alveolar processes, into the bone of the maxilla, and then it will enter and go inside. It will enter from the apical foramen. Okay. Um, so the first technique is called the supraperiosteal technique, and it's also called local infiltration. If you see two names, you have to remember both of them. This is the most commonly or the most frequently used one if you're working on one tooth. Okay, sometimes even dentists, I'm not giving you the practical part. You will get that when you go to the clinic. I'm giving you the academic part, so that's why I'm covering everything. But it's something that I know that most of the dentists in their clinic, they actually use this technique. They just go in the mucobuccal fold of that specific tooth in a 45-degree, like if it goes like this and like this, you go in between. This will be 45-degree in the mucobuccal fold, and I'm assuming now you know the mucobuccal fold. That's why I showed you the anatomical background first. Okay, and this is the crown right here, and this is a perpendicular line, and you go like 45-degree until you go above the root, and you will get this one nerve numb, this one nerve and this one teeth. The next is ASA, MSA, and PSA. Um, the mnemonic for that is 1, 2, 2. I always say it like this, and the students remember it this way. 1, 2, 2. ASA, MSA, PSA. 1, 2, 2. 1, premolar 1. 2, premolar 2. 2, molar 2. So this is ASA, MSA, and PSA. I made this picture specifically to remind you. Look at this, green, ASA, first premolar, red, MSA, second premolar, blue, PSA, second molar. 1, 2, 2. AMP, 1, 2, 2. Anterior. So ASA, MSA, PSA, 1, 2, 2. First premolar, second premolar, second molar. So I hope that helped you. ASA, here is what I want you to know. Name of the technique. Point of entrance. Number 3, what did you block? The territory. Number 4, what is the additional injection if I'm working on this area? So number 1, the technique is called ASA, and there are alternatives to that. But let's start with this. What is my point of entrance? 1, 2, 2. ASA, MSA, and PSA. So I'm doing ASA, it's 1, which is the first premolar. So this is your point of entrance. And as you see here, you're going exactly like what you see in the picture here, like this. And you're going into the mucobuccal fold. You know what is it already? That's covering the first premolar. Remember 1, 2, 2. Then what? 2 negative aspirations. Aspirations means you're pulling out instead of injecting. You pull out. You see blood, stop. You don't see blood, move in a little bit more, do another aspiration. You have to do 2 negative aspirations. If everything is fine, translation, no blood, it's negative aspiration, then you inject slowly until you get it done. By the way, just something for you to understand. Usually, you should give um, local anesthesia first, something that you put it on a mucosa. It's a local agent that I think it's lidocaine or something. I don't remember exactly, but it is something that you put it first, give the patient like a minute or something, and then you start, or a couple of minutes, whatever, and then you're going to start. This will make the first entrance less painful. It is painful, and it will be painful. Inserting the needle is painful anyway, but less painful is always good for the patients. Second is infraorbital technique. Infraorbital technique, you're targeting the infraorbital nerve as an alternative to ASA, but remember that you will get a combination of ASA and MSA. So what's the name of the technique? Infraorbital nerve block. What's the territory? The territory of ASA and MSA combined. Let me add something here. Um, Look at the green. This. What's the territory? Canine to canine from outside. I told you to remember name of the technique, point of entrance, territory, and what's number 4? Additional injection. So does anybody know the additional injection if I'm working here? Like I'm working on um, lateral incisor or canine. I'm going to give the ASA plus what? Does anybody know?
Would it be the infraorbital?
No, if, the infraorbital is an alternative for ASA. So let me do it this way. If I have these teeth right here, central incisor, nasopalatine, yes. Yes, Maisa. It is the nasopalatine, correct. So if I'm working on one of those three, okay, what's the nerve that's feeding the 3 teeth and the outside? ASA. Okay, I'm working on one of those. Is the ASA enough? No. You have to get this, which is the nasopalatine nerve. Okay, so this is the additional injection that you need to give if you're working on one of those 3. And to make it easy for yourself, canine to canine, canine to canine. This will help you with ASA and nasopalatine at the same time, both of them. But ASA is the teeth and outside, which is called the buccal aspect of the gum or the gingiva, and still canine to canine, but from inside, which is called the lingual aspect. This is the nasopalatine. So infraorbital, again, if you give like if you target, as you see here or here, you going you get through the mucobuccal fold, but you not go into that angle that you did with the ASA, because if you do it in an angle, let me show you, like an angle like this, you will go and then until you get to the top and you're going to stop. Okay, so like this, like if, let's say you go like this. If you go as an angle, let's say these are the teeth here. You go into the mucobuccal fold like this, and when you go in an angle, you will ultimately be stopped just above the root. But if you go parallel like this, not exactly parallel, but less angle, you will go up more. And this is what we need in the infraorbital technique. Look at this. So you're going to get almost the whole entire length of the needle, because you want it to go not just above the apical foramen, or not just above the root of the teeth. You need to go up all the way to the infraorbital foramen. And remember, the infraorbital foramen, the anesthesia is liquid. It's a solution. So it will enter the infraorbital foramen, getting the infraorbital nerve itself. And the infraorbital nerve feeds or gives rise to ASA and MSA. So look at this territory right here. Isn't this is ASA and MSA combined? Yes. The question is, what's the name of the technique? Infraorbital. Uh, Point of entrance. You're going to enter at some in between the canine and the first premolar, or you can go the first premolar, as if you're going the ASA, but you go up more. Okay, so they always say between canine and first premolar or first premolar, and you're going in less angle so that almost parallel in order to go all the way to the infraorbital foramen. So name of the technique, infraorbital nerve block. Point of entrance about the first premolar, just like the ASA, or between the canine and the first premolar. Number three, what's your territory? It is ASA and MSA combined. Question number four, what is your other injection? It depends. Usually you're doing this as an alternative to ASA. So you're getting canine to canine. So you're doing the nasopalatine nerve. If you're working on the first or second premolar, which is not usually the infraorbital, but if that's the case, you need to do the greater palatine. But again, infraorbital is usually used as an alternative to ASA. Next is MSA. Uh, Name of the technique, middle superior alveolar. Point of entrance, 1, 2, 2. So this is MSA, second premolar. The same thing that we did with the that we said with the ASA, you do the same here, but second premolar. You go up, and this will give you the territory. What's the territory? The two premolars and the mesiobuccal root. Not in everybody. Some people have it, or a lot of people have it, but assume that you will get it anyway. So it's part of the territory. The two premolars and the mesiobuccal root of the first molar. This is what's going to be targeted, plus the outside of the buccal aspect of the gum. This is what you get. Last question. If I do this, what's the additional technique? You always do that in your mind automatically. You put the line like this. Is that canine to canine? No. Then it is the greater palatine is the additional one. So I hope that's clear. Another technique that I was talking about is AMSA. This is also going to give you, just like the infraorbital, it's going to block both anterior or ASA plus MSA, but it's a completely different approach. And here is how to do it. The patient will open his mouth wide. You draw an imaginary line like this, like starting from in between the two central incisors. And then you draw another line uh, from the first premolar, or between the first and second premolar. You draw a line like this, and you go in the middle of that line. This is your point of entrance here. Somehow this is going to go up, and it's going to get the territory um, of the ASA and MSA, but it's going to give you both palatal and pulpal soft tissue. So this is a good thing about that, is you do not need additional. You do not need additional. Remember, ASA, MSA, PSA, these will need additional, like nasopalatine and greater palatine. This does not need, and that's why they are talking about this, and you will learn more about it in the clinic. And the other good thing about it is, when you remember when you do the infraorbital, yes, it does hurt more. That's true. Palate always hurt more. Um, so again, you will learn more about the clinical aspect of that. It does hurt more. You should put some local anesthesia first, and so on. But again, it's one injection, and it gives you both of those if you're working on multiple teeth or something like that. So it's an alternative, and again, they will give you more idea in the clinic. But the good thing about that also, beside being one injection, is remember, if you do the infraorbital, the infraorbital nerve, when it exits out, it's going to feed the nose, the lower palpebra, the upper lip. This is not the case here. You will not get those. You just get the ASA and MSA only. PSA, same thing as we mentioned, but you're not going to go straight like this, which what we did before in ASA, MSA. You're not doing that. In this case, the difference here is, what is your point of entrance, number one? Or number one, name of the technique, PSA. Point of entrance, 1, 2, 2. So this is the last one. It's the second molar, this. But in this case, you're going to go backward. You go like this, like 45 degree of this. You're actually going toward the pterygomaxillary fissure. You're not going to go all the way there. You're just going up here, and this will give you this. Look at this nerve right here. This is a PSA. So if you go like this, the solution will cover the PSA, and you're done. What's the territory? It's right here. The 3 molars minus Medubuccal root. It might not be anesthetized. Last question that I always ask you, additional injection. Here, here. Are we working canine to canine? If no, which is the case here, it's not. So you're going to be doing this. Greater palatine, or the greater palatine is the additional injection. Now, I mentioned it several times. If you're working canine to canine, you need to also block nasopalatine nerve. If you're not working on canine to canine, anything else, you need to do the inside through greater palatine. So the first one here is nasopalatine or nasopalatine nerve block. You know that nasopalatine is exiting out from the incisive foramen. So this is what you're going to be targeting. Remember this, you are not trying to get the needle inside of the incisive foramen and inside of the fossa. You do not need to do that. And that's why if you look at this Q-tip or cotton swab, you're going to actually push it under the incisive papilla, and this will point to the incisive foramen, and you're going to inject beside it. So nasopalatine nerve block, what's your target? Incisive foramen, beside the incisive foramen. What's your territory? The palate and the lingual aspect, or the inside gingiva of canine to canine, or the easy way, canine to canine. Nasopalatine, canine to canine. So you're going to put the Q-tip or the cotton swab, and then you're going to pour the anesthesia beside it. And you see the angle here. You're going like an angle here, and you're targeting this area. How to know the area? Again, you put the Q-tip, and this will lead you. You inject beside it. Where should I put the Q-tip? In the incisive, on the incisive foramen. And how to know this is incisive foramen? Find the papilla first. Under the papilla, feel, and you will see a softer, or you will feel a softer spot. This is your incisive foramen. Inject beside it. So here is a nasopalatine block. The problem is with the nasopalatine block, if you have to do it anyway. If you're working canine to canine, you have to do it anyway. But it's painful. Why is it painful? Because outside soft tissues are softer. The inside, which is the palatal side, the soft tissues of the palate, are harder. Okay, it's dense. The tissues there are more dense. So you need to put more pressure to get in. If that's the case, and generally speaking, the palate is sensitive. So you need to tell your patient, I'm sorry, it's going to be painful, but it will just take you like a second or two. Okay, so you need always give your patients heads up to expect. Don't just inject and the patient will like scream or something. Okay, always tell the patient what you're going to do before you do it, not while or after. So when you put the Q-tip, tell your patient, I'm sorry, this is going to be painful. It will take only a couple of seconds. And then you inject slowly. It will be painful at the beginning, more painful than what you're doing outside, usually. Okay, again, this is because of the trauma that you're doing from that greater pressure. Next is greater, yes, Maisa, go ahead.
I have a question about the order that we do the nasopalatine block and the ASA block. Do we do the ASA block before the nasopalatine block?
As far as I know, yes, you do the teeth first, and then you do the palate. So you do the ASA first, and then you do the nasopalatine. If you're working on the other two, you do MSA or PSA, and then the greater palatine. Okay,
Okay, thank you.
all right. So if you are working on these, like whether it's MSA or PSA, you're targeting the greater palatine foramen. How to get into that foramen? Here it is. You find this, the third molar, or between the second and the third, and you go inside. And the only way to get into this greater palatine foramen is a Q-tip, and you put it in and start to feel until you will feel a softer spot. Like the bone is underneath the soft tissue of the palate. So when you push, you're pushing bone. There is bone underneath. Until you get into this foramen, you will feel this spot is softer. Keep it there. Keep the Q-tip there, because this is exactly where the greater palatine foramen is located, and you're going to inject beside it. And it's going to infiltrate when you pull out your Q-tip, it's going to infiltrate anyway. But again, do not enter into the foramen. This is not your goal. Whether we're talking about the nasopalatine with the incisive foramen or the greater palatine with the greater palatine foramen, you're not getting inside. You actually put the Q-tip on the foramen by feeling a softer spot, and then you inject beside it. So here is the greater palatine. You palpate with the Q-tip until you get it, and you inject somewhere. The point is somewhere between beside the second or the third molar, or in between. Just feel it, and you will get it by the Q-tip, and then you inject right beside it. Now, maxillary nerve block. There are two approaches. When we watch the video, it will show you one of those two, but we need to talk about both of them because both of them exist. And again, my goal is not to tell you exactly what are you going to do like next year or the year after. Which ones are you going to use out of those? I don't know. They will tell you. We prefer this, we prefer that. I don't know. But I'm just giving you a broader aspect, and I'm giving you everything, and whatever they are going to focus on, you will know it anyway. So this is one of the two approaches to get into the maxillary nerve. Remember again, the maxillary nerve, we targeted at this pterygomaxillary fissure and the ganglia. This is the fissure and the ganglia. You're going toward the fissure. So if you inject here, the anesthesia will get in through the fissure and will get inside of the fossa. So now you get the main trunk of the maxillary nerve that's numb. Now, how you approach it? The first technique is greater palatine, but in this case, you're not doing greater palatine anesthesia. So you're not going to put the Q-tip and keep it. No, you can put the Q-tip and press it until it give you like white area, like the area will be blanching. And in the middle of that, you're going to actually enter through the greater palatine foramen, and you will go inside the sphenopalatine canal. There is a canal inside, and you will go through the canal all the way until you go to the pterygomaxillary fissure. Okay. Um, if you have the skull, here is what I'm going to ask you to do, just to imagine what are we talking about. Just get the skull if you have it, and or if you have an access to it somehow, get like a very tiny wire, or something that's very tiny, and put it through the greater palatine foramen and push in, while your eyes are on the pterygomaxillary fissure. You should know where is it. And push, 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 push. Ultimately, you will see the tip of the wire that you're putting in, like a pipe cleaner or whatever you can find. Ultimately, you will see this pipe cleaner appearing in the infraorbital fossa, specifically beside the pterygomaxillary fissure. So this will remind you that you can actually access this area through the greater palatine foramen. But in this case, you are going through inside the foramen, inside the canal, moving, moving, moving until you get there. Territory, it goes without saying. We don't even have to say it. Put everything together, all nerves. You know the anatomy, you know the branches of the maxillary nerve. When you block the maxillary nerve, you got everything. Now the question is, and I will tell you the other approach. The question is, why don't we do it and get one injection and get everything done? I told you this is complicated. You can injure something uh, while you don't need it. If you're working on one of two teeth, why would you take the risk and injure something, a nerve, or injure or get into something, a vein or artery or whatever? Why do that? So they usually keep it as a last resort, in case if they are working on a very broad area, or more if the patient have infection. The rule of the thumb is, if the patient is having infection, treat the infection and the patient come back to do the work. But what if the patient is having infection and he cannot take it, like severe pain? What are you going to do? You have to do something now. Okay, if that's the case, I will give the alternative. But the reason, the rationale behind it, if you wanted to know for the purpose of the exam or your board exam or whatever, it's because the infection slow down very much the spread of the anesthesia. So you give the anesthesia and the patient still feel it because it's very slow. The infection, there is acidity and there are chemicals that are going to delay the infiltration of the anesthesia. So that's not your best option. The other approach is called high reciprocity approach. This is not in the video that we're going to watch, but I'm telling you, this is another approach. This is exactly PSA, but instead, so it's this, remember the PSA? 1, 2, 2. PSA is the second molar, and you remember that you're not going like this. No, you're going obliquely backwards. But in this case, instead of inserting part of the needle, you insert the whole entire needle all the way until you reach this fissure. This is the pterygomaxillary fissure. So look at this picture right here, or this. You're entering in as if you're giving the PSA, but you use a longer needle, and you get uh, what is this? And you get the entire length or most of the length of the needle to be able to go all the way up there. It's a longer distance. Okay. So if you're doing a PSA, you will go like this. If you're doing this, you go more. But this is another. So how many approaches do you have? I have the greater palatine approach, and I have the high reciprocity approach, which is similar to the PSA. What are you going to get? Territory? All of this, all the branches combined, including tooth, including the outside soft tissue of the buccal, including the inside soft tissue, or the lingual? Yes, 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 it's everything. Okay,